Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome to another episode of Care Chats. I'm Danica, and I'm joined by Brooklyn and Jen, and some special guests today. Jen, Brooklyn, and I are a group of palliative care nurses who are passionate about providing palliative care and educating healthcare providers to do the same. The purpose of this podcast is to provide information for all healthcare providers on how to improve their palliative care delivery. This is our 6th episode and the final episode of our first year. So if you haven't listened to any of the other episodes, we invite you to go back and listen to our playlist. Welcome back, ladies.
Hello.
Hi.
So today we're doing something a little bit different. We're going to be answering common questions about palliative and end-of-life care. As always, Jen, Brooklyn, and I are discussing these topics from our lens and experience as palliative care nurses. But this week, we also have a few special guests who will each be answering questions from their own experience and expertise. So we will introduce them each before they speak. So we actually have a variety of backgrounds and trainings to learn from on this episode. We have taken steps to change personal information to protect our patients' identities, and you may find resources and references in the description of this episode. Please take a few minutes to fill out our survey, which will be linked in the description below, to leave us some feedback and any comments. We are busy planning for season 2, and we would love to hear from you. So to get us started, palliative care has been around in the healthcare system for many decades now, and it's offered in a variety of ways through consult teams, specialized units, specialist teams, specialized healthcare providers, through the community and home care services and acute care services. It's sort of all over. But there are still lots of misconceptions and uncertainty around this type of healthcare, both from healthcare providers and from patients and families. So today we're going to try to answer some commonly asked questions and get to the bottom of a few misconceptions. To describe palliative care and some of the misconceptions around the word and the origin, we've got Louise.
Hi, Danica. It's really great to be here. Thank you. I've been a nurse for a very, very long time, and I'm currently the executive director for Covenant's Palliative Institute. And I'm happy to tell you that my career started at the bedside in cancer care. I had a great opportunity to learn from a lot of great nurses. And at that time, Neil McDonald was the lead for palliative care in Edmonton, and Dr. Barrera was around as well. So I had an opportunity to see palliative care happening in cancer care before the creation of the Edmonton Regional Palliative Care Program. And I was really curious. It was interesting to me. I had an opportunity to walk alongside a lot of people at the cancer center who were, nearing end of life. And that's actually what I thought palliative care was about at the time. And really had an opportunity to lean in and learn quite a bit to find me in the position I'm in today.
That's great. I'm really excited to hear what you have to share with our listeners today. I'd like to start off with sort of an introductory question for you. What does palliative care mean to you? And what do you say when people tell you that palliative care means you can't do anything more with patients?
Oh, that's a good one. I love that question because when you talk to people about what it is that you do when you work in palliative care, you get a couple of different responses. People get, really, quiet. They get a little bit uncomfortable. But when you talk about the opportunity to journey alongside someone in a really challenging time and how your support makes a difference in their lives and the ability to connect with people and support them through a difficult time, people kind of tend to lean in and understand a little bit about that. When we start talking about early intervention in palliative care, that kind of confuses people sometimes. So I find myself explaining what that means. That, yes, absolutely, palliative care includes the last hours, days, and weeks of life, But there's also things that we can do when someone is diagnosed with a serious illness. And I lean into the conversation that Dr. Harvey Chachanoff encourages us to do, is to meet people where they're at and really lean into the golden rule and the platinum rule, not what I want, but what is it that's most important to them, and what do I need to know about them to be able to provide them the best possible care. And sometimes those answers are really different than what our expectations are. And I try to encourage people to think about it from the perspective of don't overthink it, but rather look at it from the perspective that it might actually save you time later on if you dive in and talk about these things now. Because if someone really isn't concerned about their pain control, but might be concerned that they're not able to make bank for their mortgage or their rent or something, you need to be able to help them. It might not be you, but you might be leaning into other people to help that person sort out some of their financial concerns, because then they're interested to talk to you about symptom management issues. Lots of times we encourage people to have conversations about what matters most to them with the people that they will ask to make decisions for them if they're not able to be able to look at some of the documentation, like a personal directive, an enduring power of attorney, a will, those simple things that all adults are supposed to have, but we kind of put off. And when people receive bad news, they need people there to listen and to support them. So it sounds kind of soft, but it's actually really foundational to building trust. I know that's a bit of a ramble, but I think that those early palliative care interventions that help people live well with serious illness set people up to have a better experience overall in those last potentially years and months of their life.
That's a great answer. I love the idea of not necessarily taking more time to get to know people, but asking the right questions and figuring out what is actually important to people. That can make such a huge difference.
It's true. I've had an opportunity as a clinician to take my hat off and be an administrator, and then take that hat off and be part of receiving care. And the things that meant most to me are the things that we hear from the literature, is that someone heard you. Having experienced that myself has been really significant, that someone looked you in the eye and treated you like you weren't made of glass, but just asked you what was most important for your person in those moments. And I think that that's kind of what our patients tell us sometimes, in residence in hospice care in Alberta, is that they tell us that we don't treat them like glass, that we still treat them like people. And being able to have those things like their pictures at the bedside, where we have an opportunity to get to know and recognize them. Those are huge. Being able to know a little bit about that person really goes a long way in terms of building trust. Because at the end of the day, people don't want to be treated like a cancer patient to be pitied. They don't want to be treated like their life is coming to an end. So therefore, I'm not going to talk to them. I'm going to talk to the person in the room with them. They just want to be seen and heard.
Another very common question we get in relation to palliative care is around opioids and addiction. There are lots of misconceptions around opioids and addiction. Sometimes even people think that we're using opioids to hasten death in palliative care. Brooklyn, can you talk a little bit about that?
Yeah, this is a really good topic, and I'm sure we could really explore this topic in quite a bit of detail, but we'll give you a kind of quick synopsis. So, even historically and today, there is lots of talk about an opioid crisis. We hear a lot about fentanyl in the communities, and there's often a stigma that comes with opioid use. So, I think it's really important that we differentiate between some of these terms that we might come across. So, there is tolerance. So, tolerance is a normal physiological response to long-term opioid therapy in a patient. And what happens is that they experience a reduced response to the medication and will require an increased dose to experience the same effect. This can vary between patients, but significant tolerance is uncommon. And an increase in dosing is usually because of disease progression. Then there's another term, which is dependence. And again, this is a normal physiological response to long-term opioid therapy in which the body adjusts its normal function around regular opioid use. So if the opioid is suddenly stopped or if the dose is dramatically reduced, the patient may experience signs of withdrawal. But then we get to addiction, and this is an actual psychological dependence. So this is when people use opioids to experience the kind of more psychological effects that come from it. And eventually it becomes a compulsion or something that they can't live without. So this often happens when the opioid is being used not to treat physical pain, and there's maybe they're using it when there is no medical reason to be using them. So, really important when we're talking about these different terms that we're reassuring the patient that the doses that we prescribe and how they're titrated are appropriate doses to balance benefit and risk. And we will closely monitor for any side effects and adjust accordingly.
I'll add on to that patients might have other fears or concerns when taking opioids. For example, if they start taking opioids early on in their illness trajectory, the opioids won't work later on, or if they take pain medication, it will mask the disease progression, or they won't be able to have treatment if they're on pain medication. So it's really important to take the time to really explore the patient's thoughts and feelings about opioids, normalize their concerns, and provide education to help patients understand their pain medication and what side effects they might have and how they can be addressed. Being proactive in providing that information can really help reassure patients. I also want to take a moment to talk about the principle of double effect. Have you guys ever heard of that?
It does pop up every once in a while.
The principle of double effect is this ethical concept that allows an action to have both good and bad outcomes. So when we're using opioids at the end of life, the intention, which is the good outcome, is to relieve suffering, so pain or dyspnea. And that outweighs the unintended potential adverse effects, such as decreased consciousness or respiratory drive. Some might argue that this principle shouldn't even be applied to opioids at the end of life because evidence does suggest that appropriately dosed opioids do not shorten survival in these patients.
Very important topic, and we always get lots of questions about opioids and palliative care and end of life care. I've also heard that palliative care is generally reserved for end of life. What do you say about any stage or any age for palliative care?
So that is a great little phrase that we like to use when we're promoting palliative care, in that it is applicable to anybody in any stage of their illness journey. And as we just discussed, hopefully by now we have learned that palliative care can be applied at any point in the person's illness trajectory. And it's not just reserved for patients at end of life or in their final stages of their illness. So just like the palliative care approach can be applied at any point in the patient's illness journey, palliative care is for anyone across the lifespan that may have a life-changing or progressive illness or a serious illness. There actually is even perinatal palliative care programs that provide specialized and comprehensive care to patients, parents, and families who learn during pregnancy or soon after birth that their baby has a life-limiting condition.
That is very cool. I did not know that existed, but it makes total sense.
So my name is Biddy. I am a licensed practical nurse who has been working in palliative care for 15 years now.
A long time.
That's a long time. I have worked pretty much exclusively at the tertiary palliative care units here in Edmonton for those 15 years. I started out actually at the Stollery and then moved to TPCU. And recently, I've also started working at a local hospice casually, which has given me different perspectives on how we do palliative care and how we all fit in together.
It's nice that you have a palliative experience in different settings. Very useful.
Yeah. Yeah.
So, Biddy, if you can answer our frequently asked question, is it only doctors and nurses who can provide palliative care?
I love this one because absolutely not. Even if you look at the nurses who provide care, there are actually different designations. So, looking at TPCU and at the hospice I work, I really believe that to give effective palliative care or hospice care, you need to follow a holistic approach, which means addressing our patients and family needs at all levels, not just focusing on a treatment plan or just medical issues. So you really need that help from outside the nursing and physician care. Our team is comprised of HCAs, LPNs, RNs, all with different backgrounds and different training. And then we also have a full ID team that assist in our care. And these include, but are not limited to, PT, OT. We have amazing spiritual care. We have music therapists. We have social work. We have psychologists, and we even have dedicated pharmacists who help with planning and treatment of our patients. And then we also have a wonderful group of volunteers who do go through a specialized training program before coming on the floor. But together we can kind of assist our patients and their families at all aspects of their life, because it's definitely not just about their medical treatment. It, affects every aspect of their life.
Biddy, I like what you said. So you really described that holistic patient-focused care that is really truly central to palliative care in general. And in my belief, it should be central to any healthcare.
All care. Absolutely, I agree. One of the most amazing thing about our unit, and I can see it in other aspects, is our communication, our mutual respect for our own practice, how we care. We don't all approach it the same way, and I think that is actually incredibly important, because every patient and family going through this journey themselves, they may have the same diagnosis, the same trajectory, but it's all different. So how you say one thing to one person may not be taken the same way by the next person. And so having that varied care and just people that they can turn to and people we can turn to is very important.
Yeah, it's helpful to have a whole team with different perspectives and different expertise.
Yeah, and one thing we do notice is with our patients, they may be more open to one thing and less to the other. So having that communication between designations allows us to cater our practice and care around the patient and not the other way around. We adjust our approach dependent on the person, not necessarily the diagnosis or the medication or the procedure. It's about the person. And that's why having all of these different people involved is so important.
Hi, I'm Vicki. I am a palliative nurse consultant at the Misericordia and Grey Nuns Hospitals, and I've been doing that for the past few years, and my previous experience before that was working at the TPCU for maybe about 12 years.
So I imagine in all of your experience that you've had lots of opportunities to discuss palliative care with other healthcare providers and answer all kinds of questions. Can you share a common question that you receive or a misconception that you often hear that you'd like to set the record straight?
So we often are faced with difficult questions from family members at the bedside. And specifically, I'd like to talk about when family members are asking how much time their loved one has left. And so that's always difficult to answer because obviously we don't have like a crystal ball, but I often explain how much change has happened with the patient. So if they're facing hourly changes, then it's a short amount of time versus days, then maybe we have days to short weeks versus weeks, and then maybe we're looking at short weeks to potentially a month. Obviously, I also go with, anything can change at any time. And at the end of the day, it's always up to the patient when they want to pass away. And I find that family members are comforted by that. They're with the patient, they're comforting the patient, they're talking to the patient, and they just want to ultimately know that they're doing the right thing. And then we also talk about the signs of end of life, like end of life teaching with the family. So that's also goes to like changes with breathing, apneic periods. The breathing will become shallow and then they'll stop breathing and start again. And then just signs of like color changes to their skin tone. Foley outputs will be lower and, they're less responsive.
I really like that you take time to reassure the family, and I feel like that can go such a long way in the end of life experience and how
panicked and scared people can be, and just taking a bit of time to say you're doing the right thing goes a
Mm-hmm.
really long way. Yeah, that's an
Mm-hmm.
important point.
And then another question was, what do you wish all healthcare providers knew about the impact of culture at the end of life? And there's been a couple cases that I'd like to talk about, just that some cultures, the talk of palliative and end of life, they're just not okay with. And it means, like, when you say palliative, it means it's the end and we've given up. And of course, we give as much education as we can that palliative, like, that's not the case. We're not giving up on the patient. We're making sure that they're comfortable with the time that they have left. But even despite all that education, sometimes family members still just have so much difficulty in letting go of treatment. So in some cases, we're seeing like family members want to continue on with antibiotics or TPN. They don't want to change their goals of care to comfort. And honestly, we just carry on like that and just comfort the family and make sure ultimately the patient is comfortable. Um, and even though the family want these things and you tell them that, it's futile, they know that. And I've had family members tell me that they know that, but they still want to continue on with the treatment. And sometimes these patients, they stay in M1 and they pass away as an M1, and that's okay. And I think as staff, we need to be okay with that and just to support the family. At the end of the day, I think we just need to make sure that the patient is comfortable and that the family know that as well.
Yeah, it kind of ties
Mhm.
into your first point about
Mhm.
reassurance and making sure
Mhm.
that the patient and family and whoever's at the bedside is having an experience that will be meaningful for them, and that's what they're going to remember.
Mhm.
I really like your answer. That's awesome. Thank you so much.
Yeah, you're welcome.
My name is Ian Simons. I'm an RN. I work at the TPCU, the Tertiary Palliative Care Unit at the Green Nuns, as well as the U of A as a palliative nurse consultant. I've been doing nursing for 3 years now, all in palliative.
We get asked a lot about starvation or eating at the end of life, but that could be potentially a whole other podcast episode. So maybe what we'll do is we'll do a little scenario and then you can tell me, how you would respond to the family. So you have a patient in the last hours or days of life. They're very drowsy. The family tells you they're worried because the patient hasn't been eating and asks you if they are starving to death. How would you respond?
Firstly, I would say that patients at the end of their life are not starving to death. It's the disease process itself that is leading to the end of their life. Oftentimes, our patients don't want food, and specifically that's because the hunger drive isn't there, because the cachexia driven by the cancer points to the fact that the cancer is stealing all the energy away from the food that they're being given. And so if anything, it's just going to cause the cancer itself to grow, cause them more symptoms and more pain and more suffering towards the end of their life. On top of that, if they're so drowsy that they're not able to ask for anything, they're also not going to be able to swallow effectively. Therefore, if you give them anything, and I say this directly to families, they're going to aspirate or they're going to choke, and it's going to hasten their death. And our goal here is to not only provide comfort, but also not hasten death and make sure that their death is as comfortable and as natural as possible. Oftentimes, as people decline, they have fluctuations in their level of consciousness. Sometimes they're awake enough to ask for food because some people want. Like I had a patient a couple of weeks ago who woke up enough to ask for a beer, and we try to meet that need, obviously. So if they're awake enough to ask for that, you can give them little bits of food, but only when they're awake enough to specifically ask. So in that case, I gave them a sponge with some Guinness on the sponge, and he liked that. Sometimes when families are told that the patient can't get nutrition via mouth, they're asking for TPN or a G-tube feed. An NG sucks and it's not comfortable for the patient to get at the end of their life. And even if the family is really insistent, the idea of NG feeds coming up and causing aspirations in somebody who's laying down and is constantly asleep is enough to make people feel skeptical about the idea of doing that. And then TPN, in patients' families who are really adamant about TPN, I often involve the doctors, but one of the ways in which I've been able to help families come to terms with the fact that TPN is not an effective treatment at the end of life is the idea that putting nutrition directly into the blood means that it has to go through the liver initially instead of going through our whole GI system, meaning it's going to be really hard on the liver. And you can usually point to patients at this stage in their life as being very frail, and families will understand that putting so much pressure on the liver is bad in someone who's so frail. And so these are the ways that I usually help families come to terms with the fact that their patient can't eat anymore.
My name is Tim Gutteridge, and I'm a palliative care physician at the U of A hospital, working here with you, Jen. And I've been doing palliative care for a bit over 8 years, I guess about 8.5 years. And before that, I was a hospitalist in BC.
So we have our frequently asked question. What's the difference between C1 and C2 goals of care?
Okay, that's a great question. And yeah, thank you for hosting me here, Jen and Brooklyn and Danica, and for a great podcast. I'll start by reading what's written in the Conversations Matter booklet, which is an Alberta resource here. And then I'll give some commentary and examples from practice. So here's what the book says. C1 means that the focus of care is to provide comfort with symptom control and using medical treatments that maximize your quality of life, rather than focusing on your length of life. When is C1 appropriate? C1 is appropriate in situations where a person is very frail or living with serious illness and is unlikely to respond to medical treatments aimed at prolonging life. It is appropriate when the person wants to focus on their quality of life more than their length of life. So that's what the booklet says about C1, which is a pretty typical kind of palliative care definition overall. So now I'll read what it says about C2. C2 means that you are in your final hours or days of life, and all treatments are focused on your comfort and support of those close to you. When is C2 appropriate? C2 is only appropriate when a person is imminently dying, i.e. final hours or days, and treatments can no longer prolong life. So that's the formal definition based on Alberta terminology. So why don't I give some commentary here and I'll unpack this a little bit. The first thing that I'll say is that not every location actually has this distinction. So I already mentioned that I was a hospitalist in BC previously. So when I was in BC, these were lumped into a single designation. So on paper, this distinction didn't exist. In Alberta here, we reflect two different palliative care populations, though in reality, there's overlap and patients have all kinds of wishes. So on a practical level, while these are both palliative care patients, the main thing that separates these groups is the prognosis. C1 patients want to focus on comfort, of course, without life-prolonging measures, but they may not be imminently dying. They may still have some time to live, which might be weeks or months or even longer. And we want to do whatever we can to improve quality of life during this time. C2 patients are imminently dying, and by that we often mean hours to days. What we do or don't do is going to reflect that. So why don't I give a few practical examples? So if we have a C1 patient who becomes suddenly delirious, I may still be having a discussion with family about investigations to look for a reversible cause, such as blood work or urine cultures. And sometimes I'll be discussing interventions such as hydration or even oral antibiotics, sometimes even maybe a blood transfusion. The goal here would be to see if we can help make them more lucid, which could help facilitate meaningful interactions and overall quality of life. Now, if I have a C2 patient who's delirious, I'm more likely to discuss aggressive medication management, and I may be offering the option of generous doses with the goal of the patient sleeping comfortably until their death. Sometimes this might involve full palliative sedation with a midazolam infusion, which is a situation where I would actually be switching a patient from C1 to C2, since the order sets generally recommend C2 for midazolam infusion. I'll give a couple shorter examples, but another example would be if a patient has a painful fracture. So a C1 patient, I might still be getting an opinion about whether some sort of surgery or intervention might help with pain for the time that they have left, if it makes sense prognostically. Whereas for a C2 patient, so if somebody's actively dying, surgery or vertebroplasty or an intervention is not going to make sense. And again, I'm going to be going straight to aggressive medication management. A final example I'll give is decisions around transfer to hospice. So for a C1 patient, hospice might be a great option, Whereas a C2 patient who's imminently dying, transfer could be distressing. There could be a high risk of death en route. So generally, I would be looking at how to quickly get them comfortable in their current setting and wouldn't be looking at sending them anywhere. So in summary, if you're going to remember one thing about the difference between C1 and C2, it's generally the prognosis, with C2 being meant for the imminently dying patient. Both designations reflect care that is, we want to prioritize comfort and dignity and support for the family, but based on the prognosis, how we're going to do this is going to look different.
Thank you for giving those examples, because I think it's really important to remember that not everything is cut and dry and everything's really nuanced. So even if we are doing investigations or certain things that might like accidentally prolong life, but our focus is on the actual symptom for a patient who's C1, like it doesn't necessarily apply to everybody.
Yeah, that's true. And we might talk about two different types of patients here. There's all kinds of patients and values and nuance. And I probably said the word might a lot. There's things that we might do in a C1 patient or we might not, but we're probably not or even definitely not going to do in a C2 patient.
Yeah, thanks for clarifying that. And then thank you for referencing Conversations Matter. So we'll put that in the resources for our episode.
Yeah, and that's a great resource. I often give the physical booklet to families, and it's available online also. And the designations we use here are kind of Alberta based, but I'm assuming kind of international listeners for your podcast as it grows. So, but it does reflect two types of patients, regardless of whether they exist on paper.
That are more comfort focused and symptom focused.
Yeah.
Thank you, everyone, for joining us on this season 1 of our Care Chats podcast. We hope by now you've gotten more comfortable with palliative care. We'll be looking at other streaming options for our episodes, so keep an eye or an ear out for that. We're looking at audio only. And then we're also thinking about maybe doing a little between season content. I don't know what the fancy Hollywood term is for that, sorry. But thanks for joining us, guys, and we hope to hear from you or see you soon.
Thank you so much. See you around.
Bye.
Bye. Take care.
Bye.